Good morning. My talk is on what determines the incidence of myopia in preterm infants with ROP. As you know, ROP, one of the main long-term complications of ROP is myopia, and there is a paucity of studies as to why this occurs. It's an observational study. The period was Jan 2020 to June 2022, where the intervention was done. But we are doing it at 4 years. It is a retrospective study to see what are the risk factors for myopia. At 4 years, we looked at the refractive criteria. The study was approved by the ethics committee, and ROP was treated according to ET-ROP guidelines with LIO using double frequency YAG. For type 1 ROP, zone 1 or zone 2 posterior was treated with intravitreal anti-VEGF. Those who completely vascularized were followed up till full vascularization, and those with recurrence or reactivation were supplemented with laser. Type 2 was observed till regression and full vascularization. This is just the history of what was happening during the time of the treatment. At 4 years of age, full cycloplegic refraction with homatropin was done. The refractive error was recorded in the form of spherical equivalent, and the refractive status was defined as myopia is a spherical equivalent more than minus 0.25 diopters. Low myopia is between minus 0.25 and minus 5. High myopia more than minus 5. Emmetropia between 0.25 and 2 diopters. And high astigmatism minus cylinder of more than 1. The uncorrected visual acuity was measured with age-appropriate pediatric visual acuity charts and Snellen chart in older children. The distribution of groups, there were 72 eyes of 36 patients, and they were divided into 4 groups. Ones that had anti-VEGF monotherapy, which vascularized fully after anti-VEGF and did not need laser. ROP laser alone done, and anti-VEGF plus additional ROP laser done, and spontaneous regression. And we had 18 patients in each of these groups. The gender distribution you can see in all the groups, and generally we had more male babies than female babies. Comparison of uncorrected visual acuity, logMAR, and mean spherical equivalent among the study groups at the age of 4 years. The mean plus standard deviation visual acuity was 0.98 in the injection group. Laser group was 0.03. Combined group was 0.17. And for spontaneous regression group, it was 0.03. But there was no statistical significance between the two. But it is clear that the visual acuity is better. Spherical equivalent visual acuity is better in the laser and the spontaneous regression groups. The incidence of myopia when we compared, it was found that in the injection group and in the combined group again had the maximum myopia, but the difference was not statistically significant between the 4 groups. The long-term refractive outcomes when we looked at the myopia and the emmetropia part, the low myopia was equal across the groups. But if you look at high myopia, again the anti-VEGF and the anti-VEGF plus laser group had more high myopia than the others, and the spontaneously regressed group did not have any high myopia at all. Comparison of anisometropia between the study groups again did not show any statistical difference. Association of mean gestational age, there was no statistical significance of mean gestational age and the incidence of myopia across the groups. And mean birth weight, when we looked, there was a significant association of incidence of myopia with the mean birth weight. Lower the birth weight, the higher the incidence of myopia. We looked at other risk factors also, multiple pregnancies, use of mechanical ventilation, and history of sepsis. Again, we did not find a statistical significance. Zone of the ROP also did not show any statistical significance. Stage of the ROP, when we looked, there was significant association between stage of the ROP and incidence of myopia. Higher the stage, greater the incidence of myopia. So in the discussion, what I want to tell is, in Tasman study, there were 10 individuals with myopia, and then they looked at what happened, and they found that it was an increase in axial length that caused the myopia in these children. And another potential mechanism that I've said is a forward lens location, and that there is incomplete postnatal growth of the crystalline lens. And in infants with ROP, the lenses do not go through the process of losing this refractive power. It is plausible that ROP, aberrant oxygen metabolism, or both may affect the normal vitreoretinal impacts on this formation of the lens. Then some other studies have found relationship between the stage of the ROP and the degree of myopia. And in our study also, we have found this relationship to be substantial. Another study showed 103 patients they have looked, and they have found that it is myopia is not related to axial length or birth weight. But in our study, we found birth weight definitely had an effect on the degree of myopia. This could be because of the increased severity of the ROP with the lower birth weight. And other studies also have found there is no difference in gestational age, duration of oxygen exposure, and the degree of myopia. So in our study, we have found that severe ROP was there in patients who were treated with anti-VEGF alone. And this is similar to Martinez et al. Study, where they studied 18 eyes with bevacizumab and found a 67% incidence of myopia. Now let us look at the comparison. So if you look at the anti-VEGF treatment, we have similar with the other studies, very high incidence of myopia with anti-VEGF alone. If you look at the laser study, the incidence again is 50%, similar to other studies. And in spontaneous regression, it is very low in our group, similar to other studies. So with this, we find higher incidence of myopia in the anti-VEGF and anti-VEGF plus laser, and no incidence of myopia and especially high myopia in the spontaneous regression group. And the only significant risk factors we found were birth weight and stage of the ROP. And this leads us to hypothesize that ROP itself, if it is severe and needs treatment, may be related to the development of myopia, and it is not the laser treatment and the scarring that was produced by laser causing extension of the axial length as we thought earlier. So treatment modality really does not have so much effect on the development of myopia as much as the prematurity itself and the incidence of the severity of the ROP. Our limitations are that we have not measured corneal curvature, axial length, or anterior chamber depth or lens thickness in our study. So in conclusion, we postulate that prematurity itself and severity of the ROP are the risk factors for developing myopia, regardless of the treatment modality used. And using anti-VEGF is not a protection against development of myopia in the later stage. Thank you, and these are my references.
A very good study, Dr. Natasha. So basically, you are saying that the mode of treatment, does it really influence the pathogenesis of myopia?
Yes, because it was
So you are studying very different modalities of treatment. But you have found
spontaneous regression also.
Spontaneous
One
regression
group
also.
which had ROP but did not need treatment.
So you said the anti-VEGF group had the highest incidence of myopia.
Yes.
Can you, what is the pathogenesis or what is the discussion that you want to give? What is the reason that you want to give? Is it independent of anti-VEGFs or just that the cases in which would otherwise become myopic, you had given anti-VEGF, or there is a correlation between the two?
Between the groups, when we looked at what we call when we compared each risk factor, we did not get a difference between the groups. But very obviously, there is a difference in the incidence of myopia in the anti-VEGF group and in the anti-VEGF plus laser group, which leads us to
just becomes incidental because basically you cannot.
That we did when we did what is that called? Regression. When we did the regression analysis, we found that the higher the stage of the ROP, you should remember that the higher the stage of the ROP are the ones who got treated with anti-VEGF, and lower the birth weight was also treated with anti-VEGF. So that kind of postulates that it is the stage of the ROP, the severity of the ROP and the zone in which it came that has caused the myopia, which means that there are some factors that are not causing regression of power of the lens, and that factors are in play with the severity of the ROP. And whether you treat it with laser or anti-VEGF, you are not intervening so much.
What is your longest and shortest follow-up in this series?
This we have done at a point at 4 years of age of all the babies who were treated between 20 and 22.
Okay.
I have follow-up, but in this study, we have taken it at 4 years of age.
Very good study and very important one also. So in these patients, whomever you are treating for ROP, what is your general follow-up? Like, do we have dropouts after they get treated, or do you keep following all of them?
No, ma'am. They are followed up for life, usually till 6 years. When they start reading Snellen properly and they don't have a refractive error, then there are dropouts. But generally, I find that when you treat ROP, the parents have a kind of commitment to follow up. If at all they don't, they do follow up in their their local
Right.
hospital.
But even among the spontaneously regress group, it is very good to see that you have such a good follow-up in your center. Because in our center, we are finding it challenging that all the spontaneously regress group, they drop out. Whereas this is very important to see later on what is
Whether
happening.
they are telling.
And in your references, I think, have you looked at the study by Dr. Savleen Kaur, who has published in JAPOS in 2019? That is a very recently done publication on ROP and myopia. So she has looked into the biometry aspect, the anterior chamber depth and lens thickness and axial length and everything. And what she says is that it is not related to axial length. It is mainly an anterior chamber disease. The pathology is totally different. That is why it is more to do with a higher anterior chamber depth and a steeper cornea. So probably
So
if
we
you
did
can
not find a study in which these 4 groups were there. So I had to compare with each group with a separate study. That is how I have done.
And another, she also found that the same thing, that laser treated eyes, somehow laser could be protective in a way that you are actually ablating the mid periphery.
We
So
actually
that
thought
is
it
the
was the
reason
reverse.
where there is a tendency for defocus, and that is why myopia will progress.
Yes,
But since the laser is creating a scar there, it may be actually preventing the defocus. So that may be a reason.
Thank
Thank you, Dr. Natasha.